This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Well, I'd love to talk to you about soccer, but I think we'll leave that for the break. So I'll just talk to you about something hopefully as exciting, or I'll try and make it as exciting, which is afferent limb failure. So let's start with a bit of a definition so that we're all on the same page. So in the context of a rapid response system, afferent limb failure is a failure to detect, recognise and trigger an escalation response to a deteriorating patient. Does it exist? Well, it does. Rapid response systems were sort of kind of the foundation is the fact that it was universally identified that patients with have adverse events have preceding abnormal vital signs that haven't been acted on or responded to appropriately. So that was the basis to rapid response systems. And on the implementation of a MET system, as we did during the MERIT study, afferent limb failure remained pretty rampant even during implementation, and in fact sort of kind of influenced the outcomes of the study. And despite its initial presence, after 8 years of a rapid response system, certainly in our institution, it still was quite significantly impacting on the way our rapid response system performed. If anything, its prevalence rate was less so than what it was in the initial period, but it still provided quite an effect. So we know a little bit about risk factors with it. We know that the delayed calls are more likely to be overnight. There's a diurnal variation associated with them. More likely to be in the elderly, and certain patients with certain triggers like reduced GCS or hypotension are more likely to be influenced by afferent limb failure. Does it cause a problem? It took a while really to establish whether afferent limb failure did, and there is a few studies out there that demonstrate that. This is one from our study where we looked at our institution, which we looked at 575 events, and afferent limb failure was present in 23% of them. Of the 23%, over a third of them had more than one episode of afferent limb failure. And patients with more than one episode of afferent limb failure had a higher mortality than those that did not have afferent limb failure. Equally, when we looked at patients that did and did not have afferent limb failure, those that did have afferent limb failure were a higher risk of having a unanticipated ICU admission. And by far the largest study population group of any, the MERIT study, reanalyzed the data there and identified that even amongst that group, the afferent limb failure was quite prevalent, and delayed calls were associated with harm. They were associated with mortality, and they were associated with unanticipated ICU admissions. And delayed calls didn't differentiate for control or intervention hospitals, but upon implementation of a MET system, the afferent limb failure amongst hospitals that were in the intervention arm was lower than that of the control arm. So let's break down the three sections: detecting, recognising, and triggering. So in detecting, most of you would be familiar with this figure. It comes from the MERIT study. We know that our documentation of vital signs is incomplete. The implementation of a rapid response system increases our documentation of vital signs, but nonetheless it still remains incomplete. And aside from just the incompleteness of our documentation, there are some inherent errors in the way we document our vital signs. And this study was with Rebecca Trickle and myself. We looked at adverse events and the presence of triggers prior to those adverse events, and we could see that they're spread over the 24-hour period. But what is particularly of note, and this study was done prior to the standardised observation charts that we're now all familiar with, that some of the values that we were getting were quite extreme. So for blood pressure, they were documenting systolic blood pressures of 40. Clinical measurement of heart rates of 220, which clearly are errors, but despite documenting that, they weren't really responding to those sort of extreme values. And to add further to the challenges of identifying afferent limb failure, the tools we currently are issued with are imprecise. The positive predictive value of the MET criteria as a group is less than 16%. The majority of aggregate scores don't get much higher than 0.8 on the receiver operator curve. And the reason for that is that if we look at patients that do have adverse events and match them with control patients and look at what their vital signs are, there's quite a bit of overlap. So, for example, here with the respiratory rate, most of the normals who don't have adverse events are in that sort of kind of range, but you can see there's quite a bit of overlap with those patients that end up having adverse events. So differentiating those, identifying the most at-risk patient, the one that's going to go on to an adverse event, can be very challenging with our existing tools. And to compound the fact about the deterioration, this is sort of kind of the paradigm that we're working with. If you look at a whole hospital approach, only less than 5% of patients within the whole hospital have triggers within any 24-hour period. And the workload of rapid response teams, or those kind of escalating, it's only about 28 to 1,000 admissions. Now that varies amongst hospitals, but if you have a low background workload, it's even harder to detect these deteriorating patients. Furthermore, not all events are predictable, and of those patients that do have abnormal signs, a large majority of them either resolve spontaneously or resolve with just some ward treatment only. And the other challenging factor here is that of patients that do go on to have an adverse event, within the 48 hours prior, at least a quarter of them don't have any documented abnormal vital signs. So picking the at-risk patient, picking the patient who goes on to have an adverse event is challenging. So now let's look at recognising deterioration. This comes from a study from the UK, from a large group of hospitals. They looked at patients who had a in-hospital cardiac arrest and what happened in the 48 hours prior to that. And this is in the setting of a rapid response system and in the setting of most of those hospitals having a standardised observation chart, and they used the mu scoring back then. So in terms of recognising patients that have a deterioration, the severity of the situation often goes unrecognised. And one of probably the basic reasons it does go unrecognised, that in the 48 hours prior to having a cardiac arrest, the highest level of oversight these patients had was a junior doctor or a nurse attendant. Consultant attendance was quite low in the previous 48 hours. So we have our most junior staff and most inexperienced staff, and the demands we place on them in terms of detecting, it makes a good sense that they'll end up failing. And when we do recognise that when there are warning signs, we often don't escalate care in a timely fashion, and our responses are usually inadequate or not communicated to senior doctors. Now that's ward doctors, and let's look at what those like us who are trained to manage acute care patients, how we perform. And we looked at all our adverse events, so cardiac arrest, MET cause, unanticipated ICU admissions, and a third of them were patients who in the previous 24 hours had been discharged from a critical care area. They were either discharged from ICU, operating theatre, or discharged from the emergency department. And furthermore, in terms of the performance of a critical care group, in terms of detecting patients who may be of deterioration that we send to the ward, we looked at those who were reviewed as part of a METCOR and those that were reviewed as an ICU consult, and 14% of the patients who went on to have one of those adverse events had a critical care type review in the preceding 24 hours. So not only is it difficult for ward-based staff to detect clinical deterioration, it also is difficult for us as clinical care clinicians. And there are other factors that also contribute to difficulties in recognising deterioration. There is a lack of awareness to the criteria. If there is a variable level of education of rapid response systems, and particular education, broader education of detecting and responding to clinical deteriorations. There are delays and failure to communicate, and there's also a failure to recognise deterioration and also to recognise the significance of deterioration. This is particularly difficult, and there are a number of tools out there that try to assist us with that, but they still remain imprecise. It would be nice to be able to forecast the potential for deterioration, but we do that poorly. And we often ask ward staff to manage patients who should probably not be in a ward environment, but be in a higher acuity environment, and may not be in that sort of environment because of resource limitations. So we've talked about detection, we've talked about recognising. I just want to cap on now triggering the response. We know that we often fail to trigger a response, and these are some of the reasons why we fail to trigger a response. Fail to trigger a response because criteria are present, but the patient doesn't look sick enough. And because I don't look sick enough, we don't feel inclined to call a MET call, because when the MET call gets there, the patient will fail the edge of the bed test, and then the ward staff feel that might make them look a little bit silly. If education is not appropriate, they might not be uncertain of what criteria or what triggers to escalate. But probably the biggest factor are cultural, and the biggest cultural factors are an allegiance to the admitting team, particularly if it's a special team, a specialty-related service, and an ongoing ambivalence of the effectiveness of rapid response team. And that combination is by far the biggest contributor to delaying or not failing to trigger a response. Fear of criticisms by the rapid response team is often cited in the literature, but if you look at the values associated with that, that isn't a frequent occurrence. What would help prompt to generate a trigger response? Clearly, the opposite to the previous slide. So, let's go back a little bit. If you participate in rapid response system education, and particularly if you're part of a rapid response system in the past, they all go for good for triggering a response and reducing afferent limb failure, believing that the rapid response system works, having less ambivalence in its effectiveness. And the rapid response system being seen as a mechanism to facilitate ward patient care rather than to take over ward patient care. Having a team that's reliable in terms of its response, and having a team that liaises well with ward staff goes far in terms of promoting triggering of responses, and also the experience of the staff making the call. The more experienced staff tend to know when to make a call and make that call, whereas the less experienced staff tend to hold back a little bit. However, these solutions are not complete. So introducing a rapid response in an education program certainly does reduce your afferent limb failure rate, but nonetheless you still get observations that aren't recorded. Introduction of the Muse does improve your documentation of your vital signs, does have a positive impact on your afferent limb failure rate, but nonetheless there is quite a significant proportion of afferent limb failure activity that is going on. People have talked a lot about automated monitors. I think it's an evolving area, and it requires a lot more work before they're implemented, particularly the costs associated with them. Certainly, automatic monitors does increase the documentation of your vital signs, but there hasn't been a lot of work done in what it does to afferent limb failure. And if anything, one study has suggested that afferent limb failure is probably higher in patients who are electronically monitored. Further potential solutions are largely speculative, but my strong belief is that if we allowed our ward staff sufficient time, training and experience to undertake a patient assessment beyond that of just taking vital signs, we would help them develop a strong sense of patient understanding. They'll hone in their intuitive skills, they'll have a better understanding of the patient, they'll recognise changes in behavioural physical signs, and they'll start to recognise patterns specific to those particular patients that would help forecast potential for deteriorating. And we need to have the available expertise. The available expertise needs to be there 24/7. Right now there's extreme donor variation amongst all hospitals throughout Australia and New Zealand in terms of expertise available at night and expertise available during the day. Potentially involving the patient and the family in terms of raising concerns may assist us. I've talked a little bit about prediction tools. We should use them as an aid, but as a standalone tool, then they're insufficient. And as well as that, it's my strong belief that we need to start focusing on individualised patient monitoring. So not all patients are at risk throughout the same risk throughout their hospital stay. So if you're admitted from the emergency department, you're at high risk within the first 24, 48 hours of having a MET call, and may not necessarily have that same risk after 4 days in your admission. And so we need to define the risk for particular patients and escalate our monitoring accordingly. And we also need to identify the particular triggers for patients. So for not every patient would a systolic blood pressure of 90 be a significant So if you've got a young patient with relative freedom from cardiovascular disease, otherwise healthy, might be coming in with an acute episode of DKA, a systolic blood pressure of 90 might not have the same impact as what a systolic blood pressure might be on someone with chronic hypertension with widespread vascular disease. So we need to target our monitoring both for the individual patient and the individual risk factors, risk period that they have during the hospital stay. Now, I just want to talk a little bit about observation and response charts. They're widely implemented, and part of the basis to the implementation was to help us detect clinical deterioration and also aid us with our documentation. So you're pretty familiar with them. They've got the standard format. They're multicoloured, and this is the one that we use within our hospital. This page here, which is the escalation response, varies amongst regions. But for us, if you're in a yellow zone, you get a nurse to have a look at you. If you're in a slightly higher zone, you get the home team to come and have a look at you. And if you're in a even higher zone, you'll get the MET team to come and have a look at you. And these are all mandated escalation responses. So now if we use this chart, use this tool, automatically our definitions of afferent limb failure is broadened because we have a number of escalation responses. And these escalation responses potentially could be interdependent. They were designed this way so that if you have a nurse review, nurse comes and looks at you and potentially prevents you going from there to there. Similarly, if you have a home team review, potentially prevents you going from there to there. So we looked at the charts and we did a prevalence and incidence study on the charts to look at the incidence of the triggers amongst general medical and general surgical patients in a 24-hour period, the prevalence, sorry. And we also looked at the incidence of about 200 patients throughout the whole hospital stay. And no surprises, the lower level triggers were highly prevalent and their incidence was high, and also the MDT triggers were highly prevalent and their incidence was high. But afferent limb failure was pretty high overall across all levels of escalation, and particularly at the lower level of escalations. Now we don't quite yet know what impact a high level of afferent limb failure has at the nursing level has for the MDT or the MET level, but nonetheless, despite having these tools, our afferent limb failure particularly remains quite high. So maybe we need to look a little bit beyond the patient observation charts, and this goes back to the study from the UK of patients with a cardiac arrest. Certainly monitoring is very important, and we know that, and there's no denying that. But monitoring may not necessarily be as important as it is to making decision-making, okay? To having a good examination, a good treatment plan, getting your diagnosis accurate, recognising the severity of illness. And a lot of that comes with expertise. And I think part of the biggest deficiency is the lack of expertise to make these high-level decision-making, and take some of the pressure off our reliance purely on monitoring to detect clinical deterioration. So in summary, afferent limb failure remains a problem, and it does limit rapid response system performance. It does cause patient harm, and really I don't believe there's any single strategy that is a complete solution to afferent limb failure. There are significant barriers, particularly cultural and system barriers, that remain a challenge, and until we address those, I don't think we're going to make too much more of an impact on afferent limb failure. Risk factor mitigation is often overlooked, and what we really need is a multifaceted, long-term strategies which we continually evaluate, re-evaluate, and plan and improve upon. And afferent limb failure should remain an area of ongoing investigation, and it should be one that we regularly report upon in terms of performance. Thank you.